So, good evening and welcome to our virtual program, Motherhood, Mind, and Body. We're very grateful to have doctors Regina Kaplan, Nina Ross, and Stephanie Sansone with us tonight. A little bit about our speakers. Dr. Regina Kaplan is board certified in obstetrics and gynecology. She graduated from Downstate Medical College in New York. She has 28 years experience in private OBGYN practice. She currently is the section chief Department of OBGYN at Hackensack University Medical Center, and she is also an assistant professor at the Hackensack Meridian School of Medicine. Dr. Ross is a reproductive and forensic psychiatrist. She completed her undergraduate degree at Yale University for her medical training at New York Medical College, her psychiatric training at the University of Pittsburgh Medical Center, and her forensic psychiatry fellowship at Case Western University. At Hackensack Meridian Health, she serves as the section chief of reproductive psychiatry and program director of the Forensic Psychiatry Fellowship. She has published and presented locally and nationally on a variety of reproductive psychiatry and forensic psychiatry topics. Dr. Ross is also an active member of the American Academy of Psychiatry and the Law, where she currently serves as the co-chair of the Gender Issues Committee and the Early Career Counselor-elect. Dr. Stephanie Sansone is a fellowship-trained obstetrician gynecologist specializing in urogynecology and reconstructive pelvic surgery. She is passionate about delivering evidence-based practices in all aspects of treatment for pelvic floor disorders, beyond conservative management and in-office procedures for conditions such as pelvic organ prolapse, urinary incontinence, and overactive bladder. She is experienced in robotic, abdominal, and vaginal reconstructive surgery. Following her undergraduate studies at the University of Notre Dame, she attended medical school at Weill Cornell, OBGYN residency at the Hospital of the University of Pennsylvania, and fellowship at the New York Presbyterian Weill Cornell. Dr. Sansone is thrilled to be practicing in New Jersey, where she grew up, to provide patient-centered care for her local community. So at this time, I welcome the doctors, and I will turn it over to Dr. Kaplan.
Hi there. I'm happy to be here tonight to talk to you about the fourth trimester, the postpartum period. Recently, the American College of OBGYN, ACOG, has redesigned thoughts about postpartum care. And this was to reduce maternal morbidity and mortality related to complications in the postpartum period. ACOG now recommends that postpartum care should be an ongoing process, not a single 6-week visit, and that all women should have contact with their providers within the first 3 weeks postpartum. Timely follow-up is crucial, especially for women with chronic medical conditions. Postpartum recovery occurs in the weeks following birth to anywhere between 6 months and 2 years. The weeks following birth set the stage for long-term health and well-being. It's a time of adaptation, physical, social, and psychological. It's a period of recovery from the physical childbirth. Women must adjust to their changing hormones. The newborn is challenging as far as learning to feed and care for the newborn, learning how the newborn fits into the family unit. And postpartum care should be especially tailored to each woman based on the circumstances of their pregnancy, their medical history, and the ongoing postpartum situation. It's important to start planning for postpartum success in the prenatal period. It's important to discuss a postpartum care plan with your OB provider. This is to anticipate challenges that are related to your personal history and pregnancy diagnoses, and also to plan ahead for a postpartum contraceptive strategy. We also need to address the transitions to parenthood and any potential difficulties. Prior to leaving the hospital, the postpartum care plan should be reviewed and updated. You want to ensure the next point of contact with your provider You also want to make sure before you leave the hospital to have necessary contact information, especially for emergencies. If you have a chronic medical condition, you need to schedule your outpatient appointments prior to discharge. And if you've experienced a complicated birth or fetal loss, you will require multiple early visits to foster postpartum recovery. Some of the common postpartum issues that may occur are heavy bleeding, incisional or perineal pain, physical exhaustion, baby blues, and lactation difficulties. Each of these can be a common issue that can be communicated with your healthcare provider. At times, it may just require a phone call. At times, you may need an earlier visit or an emergency visit. And at some points, you may need to come into the hospital or to the emergency room. Mood and emotional well-being, I know, is going to be handled by my colleague, but just a couple of points. 27% of women in the United States have been diagnosed with a mental health condition. And during pregnancy or postpartum, approximately 1 in 5 women will develop an incidental mental health condition. And in spite of how common this is, these conditions are often ignored or undertreated. Various means of therapy have been found to be effective in managing these conditions. Infant care and feeding also is a complex issue. Lactation help is available. You can see the link here for lactation resources in our hospital system. Just some points to consider. If you're breastfeeding your baby, it's been suggested every 1 to 2 hours is normal, occasionally up to 3 hours. And as far as formula feeding, every 2 to 3 hours. It is known that after 2 weeks, infants should be fed when they seem hungry, which is on-demand feeding, or by your schedule that you've established. In the first 2 weeks after birth, however, on-demand feeding is not always the best choice. Babies should not go more than 4 to 5 hours without eating, and 1 wet diaper is expected at least every 6 hours, so you know the baby's being hydrated. Breastfeeding and chest feeding are good for your baby and good for you. Breast milk has the right amount of fat, sugar, water, and protein. Breast milk contains also antibodies that protect your baby, and breastfed babies seem to have less sudden infant death syndrome. Your diet when breastfeeding should include an extra 450 calories per day to make breast milk. You want to avoid eating fish with high mercury levels, which varies from area to area, and you can check the FDA site for recommendations in your area. And also be sure to continue your prenatal vitamins. As far as caffeine, less than 200 milligrams a day is suggested. If you choose to drink alcohol, after a single drink, you want to wait 2 hours prior to breastfeeding and drink plenty of fluids. Sexuality in the postpartum period is complex. As you can see, it's affected by so many of the changes that you experience in the postpartum period. Breastfeeding affects hormones. It also affects your time. Being on demand to your baby also makes you less available for intimate partner time. Obstetric trauma involves the areas that are involved in sexuality and may require an extended period of time for healing depending on the nature of the trauma. Sleep deprivation definitely affects our hormones and can decrease the sexual desire. Role changes in the relationship may also affect sexuality between partners, which can also lead to relationship stress. My colleague is going to discuss stress urinary incontinence, I'm sure, and some of these other things, as well as perineal trauma. But things like medication effects, if you're on new medications postpartum, if you've had medications adjusted, new contraceptive methods, they can affect your sexual function. Substance abuse is always something that can affect sexual function. Newborn health issues may cause anxiety, which also decreases your sexual desire. And your body changes. A lot of women are affected by body image changes, which result in changes in their experience of sexuality. For postpartum contraception, it is important to discuss it in the antenatal period. It's also important to bring it up while you're in the hospital. You want to talk about options for immediate postpartum contraception, things that can be done while you're in the hospital, or at least ordered or recommended while you're in the hospital, are the Depo-Provera injection, the Mirena IUD, the Paragard IUD, and the progesterone-only pill. Contraception after 28 days postpartum, the recommendations for Nexplanon, which are the contraceptive implant, have been in the past to wait 28 days postpartum, but we do see, based on recent studies, that you can actually use that or have that implanted earlier in the postpartum period. After 6 weeks postpartum, you are again able to use combined hormonal contraception, which may be an easy method for certain people. Things to think about are inter-pregnancy interval. What we find is that intervals between pregnancy less than 6 months are not really recommended because you're still healing. The optimal time to start has been recommended to be after 18 months. Short interval pregnancies can interfere with the success of vaginal birth after cesarean. That's just it would be more of an option to you if you've had a cesarean section and you're looking for a vaginal experience next time, to maybe wait that period of time between pregnancies. Sleep and fatigue are just a function of being a mother, especially in the postpartum period. Your sleep is fragmented for up to 2 years. And if you have another child, it can continue. It's a contributing factor to postpartum anxiety and mood disturbances. You can develop good sleep hygiene before pregnancy and also during pregnancy to see really what helps you, and what kind of routine you can establish, which will lead to better sleep. And you also want to welcome family and social support to really ensure that you get an appropriate amount of sleep, at least most days. Physical healing, we talked a little bit about trauma to the tissues from cesarean section and perineal trauma, but there are many things in the mother's body that must return to their baseline physiology postpartum, and this takes various numbers of weeks and months. Yes, lacerations require various amounts of time to heal, and they may need further evaluation in the postpartum period. Cesarean section recovery proceeds over a 6-month period where you get revision of the scars and healing of all the tissues involved. Another thing to consider is that mastitis is a common occurrence for women that are breastfeeding or chest feeding. And that is something that needs to be addressed because it is a very, very symptomatic infection. And, it can be addressed by some methods at home at times. And also it's also good to involve your physician, your provider, or a lactation specialist. Chronic disease management is important in the postpartum period. For hypertensive mothers, they should be seen between 7 and 10 days for a blood pressure check and any medication adjustment that is needed. Mothers with a history of depression or with signs of postpartum depression need early in-person checks. Infections can occur after birth, in cesarean wounds, or in the perineal area that will need immediate attention. Lactation difficulties also must be addressed promptly to ensure breastfeeding success. Chronic conditions such as thyroid disease, diabetes, and seizure disorders will require medication adjustments postpartum. And patients that have had complicated births and fetal loss will require as we said before, multiple early visits for recovery. The last thing is a return to health and vibrance. Pregnancy is a natural state. However, it is not our usual state, at least not initially. And it takes various interventions, personal and from your community and from your health team, to ensure your return to health and vibrance. On average, this period of time between when you've delivered and when you feel like your normal self has been reported to be over 6 months to 2 years. Thank you. Oh, I still have more. I'm sorry. I thought that was my last slide. Hormonal changes occur in the postpartum period. These are the hormones that are most related. Estrogen decreases in the postpartum period. And that has multiple effects. It affects sleep. It affects the nature of the tissues in the perineal area. It affects just a lot of our sense of well-being. Estrogen is responsible for a lot of our sense of well-being. Progesterone too, after the placenta and baby are delivered, decreases to almost nothing. What we notice with that is just maybe some absence of some of that normal sense of well-being, but that's mostly related to estrogen. Oxytocin increases because it's involved in labor. As you know, that's what Pitocin is, and naturally it's secreted during labor. After labor, it's important in milk letdown, so it's integral in breastfeeding. And prolactin increases in the postpartum period to produce milk.
Awesome. I think that was Thanks, Dr. Kaplan. That was a great review of the postpartum period. Again, I'm Dr. Sansone. I'm one of the urogynecologists. And at this point, you're probably asking potentially what even is urogynecology. So I'm going to help walk you through the pelvic floor. What is it? And then what can go wrong when you should see a pelvic floor physical therapist or someone such as myself, a urogynecologist who specializes in these disorders. So first, to review what the field of urogynecology is, simply put, as the name may imply, it is a hybrid between the fields of urology and gynecology. So those that have completed either an OBGYN or urology residency can then go on for specialized training for fellowship in urogyn and reconstructive pelvic surgery. Our primary focus is on improving the quality of life of our patients in regards to the pelvic floor. So I would say the big three common diagnoses that we help women with are bladder leaks or incontinence, overactive bladder, and weakening of the pelvic floor, or a condition of a vaginal bulge called prolapse. So first, what I want you to do is envision the pelvis as a bowl. So there's the bony structures of the pelvic bones on the left. And then it's sort of, whether you realize it or not, in the shape of this bowl shape, where the bottom of that bowl is actually a sheet of muscle. So if you look at this cartoon of the pelvic floor from a woman sort of cut in half and viewing her from the side, you can see that the teal area, the pelvic floor, is truly at the bottom of your core as a sheet of muscle. And within it, contained in there, is your bladder in the front, with the urethra is the tube from the bladder from where you pee from, the vagina. And on top of the vagina sits the uterus, and posteriorly or in the back is the bowel, and then the rectum, where you have bowel movements from. So as you can see within this bowl, there's actually, multiple different organs that sort of live there. And that's why my job is to educate women about how to take care of it. So you could see how it is the foundation of, how we stand and sit and have, bowel movements and urinate. But these muscles, my job is to draw women's attention to them as we may forget about them in our busy lives. So pelvic floor disorders, they're very common, affecting up to 1 in 4 women, though likely this is underreported given women don't really talk about this at the dinner table or at your cocktail parties. And certainly, our mothers and grandmothers didn't necessarily talk about it much, given our field sort of became mostly popular, I would say, even though it was certified in the 70s, 80s, really became popular, I would say, in the 90s and early 2000s. So the biggest risk factors for pelvic floor disorders, which I'll go into in a moment, are pregnancy and childbirth. And this doesn't necessarily have to be vaginal deliveries. It can also mean C-sections as well. As we age and enter menopause, again, as we lose estrogen, that causes weakening of these tissues. Constipation and straining, you can imagine if you're always sort of pushing and bearing down or straining, that would kind of cause stress on those pelvic floor muscles. In the same vein, weight gain, especially central obesity, would also add extra pressure on those muscles. Some of this, of course, can't be avoided if there is a genetic component, or your mom had prolapse, your grandma, your aunts, or if you have history of hypermobile joints, you might be at increased risk. Stress and anxiety for sure. Just like you might carry, stress and have knots like in your neck and always kind of carry that weight with you. Similarly, people can carry that stress in their pelvic floor as well. So when we're doing things like heavy lifting and high impact activity, it's always important to be mindful. Are you stressing these muscles, or are you engaging your core more so than the bottom of your core? And then finally, prior pelvic surgeries or cancer treatment, radiation to this area are also risk factors for pelvic floor disorders. So I like to break up these conditions kind of within sort of their compartment of the pelvis. So first, discussing issues with the bladder. Incontinence is certainly the one that most people feel, um, bothered by, embarrassed, and certainly we see delays in care for this. And this is broken up into several types of leakage. So that gotta go with an urge and not making it in time is called urge incontinence. That with activity, so coughing, laughing, sneezing, that's called stress incontinence. Not mental stress per se, but again, that stress and pressure on the pelvic floor with a cough, sneeze, or bearing down. The most common is actually in combination of both stress and urge. So if you're not quite sure which one it is, I will say you're in the majority in that most women experience both. In that same vein, overactive bladder is kind of, when you're always having to leave that important event or that important meeting you're in, or trying to map out bathrooms because you go very frequently, defined formally as more than 7 times a day, urgently, or being awakened, at nighttime to go. So these are all conditions with the bladder that I see commonly. And here's a little graphic from our society where you see when a woman's kind of coughing, it causes sort of pressure from the belly or the abdomen on the bladder. And if your pelvic floor muscles are weak, you're more likely to have a leakage accident, as opposed to if you're able to contract and have strong pelvic floor muscles to hold it in. Following that, in terms of the bowels, very common in women, especially in pregnancy and postpartum, with those vitamins that everyone has to take, is constipation, defined formally as 3 or 4 movements a week. And even if, you go every day, so you might not think you're constipated, having like pebbles, pellets, hard stools also counts as constipation. I don't have it on this slide, but there is like a stool scale, and you really want your poop to not quite be like a toothpaste consistency, but soft, no pebbles, things like that. I tend to have to remind women that even with the movement every day, it should be a nice soft formed consistency. And the reason why is because if you're straining and feeling incomplete emptying, again, that stresses the pelvic floor, increases your risk for issues with prolapse and other weaknesses. On the contrary, one that's less talked about than constipation is accidental bowel leakage, which also first line treatment is typically working with the diet and nutrition. But again, if you're having issues with that, there's certainly things we can do. And then of the third, that's where I talk about the pelvic floor weakness or prolapse. Simply put, even though it's kind of sounds like a formal term, the way I describe it is just it's a vaginal hernia, just like you have a hernia of the belly button or the groin. The vagina is a potential space. And so you can have the bladder, the rectum, the uterus kind of bulge into that space and have that feeling of pressure and causing difficulty using the bathroom, discomfort with intercourse, and other issues. And like I said, it's usually a combination of those three compartments, like a bladder being dropped, the top of the vagina, or the rectum. But a urogynecologist would be able to sort of stage that out and tell you exactly which compartment you might be feeling discomfort within the vagina. So this is sort of a big take home I want a lot of our postpartum moms to take, is that, and I know the picture is a little graphic, but I really think that in the midst of a delivery, there's so much going on that often you kind of leave the hospital not even knowing what happened, right? You know you had a vaginal delivery, you know you had a C-section, but actually knowing the details of what happened in the delivery room, even though your providers round on you after the next day, they tell you, you're in just such a fog. And so I think it's important that, the postpartum visit or just kind of in your brain to sort of know like the details of your delivery as best you can. And that could mean whether you've had an operative delivery, the use of vacuum or forceps. And specifically what I get asked about a lot from moms is talking about the tear or the perineal lacerations. So again, I know this picture is a little graphic, but I think, it's important to educate ourselves that most women have a tear at time of delivery up to 80%, okay? And that they're graded on a scale of 1 to 4, 1 being a superficial abrasion, 2, which is the most common, or a second degree, is tearing of the perineal muscles. And then what I highlighted and italicized are 3rd and 4th degree lacerations, which according to, our Urogynecology Society, given those 2 tears involve the anal sphincter itself, we are recommending, especially at Jersey Shore HMH facilities, that there should be prompt urogynecology follow-up after that to counsel you about pelvic floor disorders and sort of steps you may take for, safeguarding your pelvic health down the line. So we're able to get patients in pretty quickly after having one of those tears. Episiotomies are no longer routine on the OB floors. However, in certain times they are absolutely necessary. And, the baby's in distress and they're needed to help guide the baby out. But of course, this can also cause some pelvic floor issues. So again, these factors we know are tried and true. Paper after paper show that they increase your risk of pelvic floor disorders. So just knowing the details of your delivery is definitely helpful. So now you might be saying, when should I see a urogyn for this? The answer, there's no right time. It's okay to be proactive for a pelvic health assessment. But I will tell you that most surgeries and procedures that we recommend be done after childbearing is completed. And we're definitely accustomed to meeting patients at all life stages. And how I think about it is particularly when patients might feel the most vulnerable. So postpartum period, after pelvic floor healing, entering menopause, after there's less estrogen, kind of keeping the vaginal environment healthy. That's called the genitourinary syndrome of menopause. It's a very formal title, but basically when there's less estrogen in the vagina, it leads to some of these urinary symptoms. But in general, when symptoms have become bothersome and you'd like to hear about your options, perhaps pursuing different options is when to meet a urogyn. I do want to touch upon, for most of these disorders, pelvic floor muscle exercises are first line treatment. So what does that mean? So Kegel exercises is sort of what everyone thinks about when they think of pelvic floor, muscle exercises. And what I want to emphasize is think about it's the pulling up of the pelvic floor up and in with contracting the muscles as if you're holding in urine, but then it's also the relaxation of those muscles. So for example, if you do a hold of 5 seconds, you also want to do a relaxation of 5 seconds so that you can differentiate the difference between the two. I'm not paid or related to this device, but this is one device that I sometimes recommend for patients as an at-home trainer called the PeriFit. The reason why I like this, what it is essentially, it's a vaginal insert with an app that connects to your phone. So when you squeeze it, it shows that you're squeezing, and when you're relaxing, you're relaxing. There's also little games you can play, but I have a patient that actually showed me, it gives you a report card of how well you're doing your contractions. So I like it because scientifically it's a form of biofeedback. So it's giving you feedback as to how you're actually exercising your pelvic floor. But I will say you have to be an active participant with these types of exercises, whether that's knowing you can do it self-directed or seeking out a formal pelvic floor physical therapist. This would be a private specialized therapist that you typically female working one-on-one in a private environment that would work actually internally, doing internal vaginal work as well as core and muscle breathing as well. And you wouldn't see immediate results. So I always tell patients to give me at least, 4 sessions with the PT or a good month or 2 of doing this to see improvement. And just a little bit of data just to throw out, patients say, should I be doing pelvic floor physical therapy while I'm pregnant? So just to get, a little in the weeds with some of these details and statistics, pelvic floor dysfunction occurs, I would say, up to 50% of women around childbearing and postpartum. You're looking at a third with incontinence and around 4 to 5% with fecal incontinence. So it's very common, and we understand that. A Cochrane review, that's a large database that kind of pools together studies that were conducted to give us summaries of the data when they looked at patients who were pregnant who went formal pelvic floor physical therapy. These 6 studies showed that this lowered the risk of incontinence in the 3rd trimester. This also persisted 3 to 6 months postpartum. And then, unfortunately, for those that were at least 6 months postpartum, so after that 6-month period, they didn't see the decreased risks of incontinence they had previously seen for those who were closer to delivery. So how do I interpret this? I say that doing physical therapy while you're pregnant would be helpful in the short term. And if, immediately postpartum, at that 6-month mark postpartum, if you're still leaking, if you're still having these issues, absolutely reasonable to reach out to a urogyne beyond pelvic floor therapy. And then, another study that looked at postpartum, so those patients that started the therapy after delivery, a few more studies reported in this one, they showed again that the physical therapy patients were less likely to report incontinence. And additionally, they were less likely to report bothersome prolapse up to 6 to 12 months. So even if, you weren't going to physical therapy while you were pregnant, postpartum, if these are issues you're having, still reasonable to start. And the bottom phrase that I stated, they actually showed in some of these studies, though not statistically significant, that there's trends of reducing a prolapse stage within 1 year with dedicated PT. So I think it's important for moms who maybe, just had a baby, want to have a baby in a few years, not to rush to think that, their prolapse is going to get worse with the next one, or these conditions get worse. You can work at PT in between pregnancies and these conservative measures before seeking, further lines of therapy. Physical therapy beyond just working with incontinence and prolapse also helps with pelvic girdle pain, separation of pelvic floor muscles, definitely something to look into because they'll do core exercises as well as vaginal work. Scar pain, so at those perineal laceration repair sites, at C-section scars, and also just things that you don't think about when you're holding a baby in the middle of the night, your posture, how you're sitting when you're breastfeeding, all of these things physical therapists can go over for both patients who have had vaginal and C-sections. I just want to give a quick plug for vaginal estrogen because I don't think a lot of people realize in postpartum moms, a Dr. Kaplan review that estrogen drops in the postpartum period, particularly if you're breastfeeding because prolactin or that milk hormone is totally taking over the glands that produce all your body's hormones. So that leads to almost, we say, atrophy or lack of estrogen in the vaginal environment, which can cause dryness, vaginal pain, issues with intercourse, and recurrent urinary tract infections. So I always say you definitely ask your provider if you're breastfeeding and having vaginal symptoms about the use of vaginal estrogen in the postpartum period while breastfeeding. This does not increase your risk of breast cancer, stroke, or blood clots. It's just a vaginal application, just a little pea-sized amount put in the vagina twice so you get bedtime. So it's just local application only. And then just a few other pearls I have. Intercourse will certainly feel different after a pregnancy, regardless of your mode of delivery. What I always tell patients is that partner communication is key. Certain positions might feel better than before. Lubricant is also very important. Vaginal estrogen therapy, as discussed. I also want to say, like, everyone thinks pelvic floor PT, they think Kegel exercises. Sometimes patients actually have the opposite issue. So think of patients with endometriosis or interstitial cystitis. They tend to have tight pelvic floors. So sometimes going back to, your Kegel exercise, pelvic floor relaxation, or that second component of a pelvic floor contraction, is key. And PT can help with differentiating those two. And I always plug getting into the habit of pushing to pee. I think a lot of moms start doing that because they're rushing to the toilet. Really, the way to pee is just relaxing the pelvic floor and letting the bladder contract. So not trying to do like a toilet dance or anything like strange or out of the ordinary. But again, I truly love my field, and in Urogyne, you're in the driver's seat. So management ranges from conservative treatment to surgery. And you really, please don't feel embarrassed. These conditions are common. It's just rarely spoken about, but we're here for you. And given that, I'll pass it over to Dr. Ross.
Thank you, Dr. Sansone. So I am a reproductive psychiatrist, and I'm so happy to be speaking with all of you. The first thing, just to kind of zoom out and talk about the postpartum period. Part of the I have a lot of animations, Dr. Sansone. Just to kind of like put this together. Pregnancy, there definitely is an image that a lot of my patients and people in general have about pregnancy being this magical time. It actually, even without complications, is filled with a lot of things, such as, I think you can just keep clicking, Dr. Sansone, each one is morning sickness, which I put in quotes because it often is not in the morning, it's throughout the day. You can just keep, fatigue, trouble sleeping, breast pain, peeing all the time, clothes don't fit, back pain, reflux, swollen feet. So this is all like, I think all of these, and I hope my OBGYN colleagues will agree, like a lot of these things are just kind of inevitable. Just because that is how your body changes to prepare for baby, or just as a result of the physical changes. And next slide. Just part of the standard package, complications aside, pregnancy is a major life change. Your role is shifting. There are often a lot of financial stressors, or at least reallocation of, funds you would have maybe spent on more fun things now have to be spent on daycare and all of the baby gear. Infant care, there's a steep learning curve. My husband and I are both in medicine. My husband's a urogynecologist too, and I obviously do reproductive psychiatry, but even we were shocked when we actually were face to face with our now toddler. We were more prepared than most, but even we were like, what did we get ourselves into? Sleep deprivation, as my colleague said, it's pretty much part of feeding a newborn in the beginning, and it's just part of the package. Hormonal changes too are part of the package. And as we talked about, physical changes and recovery this is all just kind of standard for your average uncomplicated birth. Throw in some complications and you have a lot of big stressors going on. Next. So I like to think of, one way I like to kind of holistically think of mental health and kind of your mental health journey is, think of your brain as a bucket. So the more you want your bucket to be as full as possible. And the more full your bucket is, the more you can, like a fancy term is emotional reserve. But the more stuff that's in your bucket, the better you can withstand all of the stressors that are inevitably part of life. The stressors happen every single day. If you have more stuff in your bucket, it's easier to kind of withstand that without feeling terrible. Next, please. So there are all kinds of things that empty your bucket and all kinds of things that fill up your bucket. And I find it's really, really helpful when thinking about mental health at any given time or with any given issue to kind of take an inventory and, of all the different things that may be emptying your bucket or filling your bucket at any given time. You can just kind of press ahead. I think they might. So like major life changes, even if they're good ones, stressful, sleep deprivation, hormonal changes, physical changes, recovery will certainly deplete your bucket. Genetic susceptibility, for example, to psychiatric illness, any negative relationships, the list, any stressors, the list can go on. These are just some examples. And some examples of things that can fill up your bucket include things like therapy. It can include psychiatric medications, a support system, good relationships, meaningful activities, things that bring you joy. Some major life changes can be both filling of your bucket and take away from your bucket. Things can be both. Exercise can fill your bucket, meditation can fill your bucket, puppies. The list is very personal. It can change, day to day, year to year. And I do think it can be helpful to think about, of the things that are emptying and filling your bucket, what do we have control over? And what don't we have control over? So a lot of the things, just to emphasize this one time, a lot of things in the postpartum period we just don't have control over. It just is what it is. You're going to be sleep deprived in the postpartum period. It's good to strive not to be and to try to maximize that, but a certain amount of sleep deprivation happens. You can't, if your mom had a history of anxiety, that's not something you can control. But I do, when I am thinking about treatment, I do like to focus on the things that we can control. So, for example, that includes minimizing any unnecessary stressors, if possible, getting into therapy if that's feasible for you. Medication is a big thing I focus on as a psychiatrist because it's something that I can, control right here in the moment when, so many things may be out of our control. And I think next slide. And if you like puppies, obviously I wouldn't recommend getting a puppy in the postpartum period, but, so I find it is helpful. Can you just go back for a sec? I find it is helpful, when you are thinking about your postpartum mental health. This is an exercise you can do every day, as you're kind of going through the journey. Think about what's emptying your bucket, think about what's filling your bucket, and think about what you can change. Now you can go to the next. So I also kind of think holistically. I don't want to underemphasize what an important life stage being a new mother, being a mother of now 2 children, multiple children is. And there is this concept in literature and kind of any story called the hero's journey. And you can see the hero's journey, basically almost any movie you have with this kind of arc has a hero's journey where there's kind of a start. A person is called to adventure. They meet a mentor, they cross a threshold, they have challenges, they grow, they have death and rebirth, they transform fully, they change more, and they're finally able to face the big challenge, and they return home, but a little bit changed, a little bit better. You can see this kind of pathway in any number of films or movies, including like Star Wars, but also including things like Legally Blonde and Mean Girls. It's a very classic adventure that is kind of a nice way of, I like to conceptualize like what it is to kind of go through this journey of motherhood. A question I've been asked before that I think is a great question is like, will I ever return to normal? Like, will I be different? And I do, I think if you go to the next slide, I think that might be. Oh, okay. I already put this in. Well, so anyway, so I like to think of motherhood as, it always kind of helps to, it makes it a little bit more fun and palatable to kind of put motherhood in this context. So you initially have the call of adventure where you get the positive pregnancy test. Sometimes there's the refusal of the call where, you're kind of a little nervous. You meet your mentors, your allies. That can include your reproductive health team, your friends, resources you meet. There's crossing the threshold, which is having the baby. There's tests, there's failures, there's growth, there's rewards, such as seeing your baby's first smile. There's further obstacles, and then there's rebirth and returning to who you were, but a little bit changed, a little bit better. Next, please. Oh, I don't know. I think you could just, okay. So yeah, it's just some examples of things that are tests as you kind of go throughout the mother's journey. It can include things like not having time, peeing when you cough, financial stressors, caring for an infant, navigating relationships, breastfeeding, peripartum depression and anxiety, returning to work, role shifting. These are all things, again, I'm not trying to, I think people often underemphasize the importance of these significant changes and what a toll they can take on mental health, even if there is no peripartum or postpartum depression or anxiety going on. Even for someone without that happening, these are significant challenges and significant changes that make this period of time an especially vulnerable time. And mommy brain, which is a kind of way of, I don't know if I love the term, but it's the brain does change a little bit during pregnancy in certain ways. Although it is actually, I did hear someone recently was like, maybe part of mommy brain is like actually all the additional stress and maybe not equitable division of household labor during the postpartum period. So, but there are physiological changes in the brain to a certain extent. All right, next, please. Boundaries. This could also be boundaries, sleep deprivation. Basically, there's a whole lot of things going on. This night sweats. This may be the first time you have really established boundaries with, your role as mom, your role as, with grandparents, with family members. Anyway, all of this to say it's a very vulnerable time. Don't underestimate it. Another point I just want to add in is these are, speaking of kind of mentors and allies, I have a list of recommended resources that I love to share with my patients. It includes some really, really helpful authors and I guess authors, psychologists, people on reliable sources on Instagram, people who have books that have been really, really helpful, because so much of this is about assembling your set of tools to address this gigantic change in your life. Next, please. And so, yeah, I recently heard the word matrescence, which refers to the process of becoming a mother. And I think it's a great concept and is a great reminder that the process of becoming a mother, like other times of change, like adolescence, it is a change. It is a change for the better. It is a challenge. It's a journey. It takes time. And to give yourself the time and the self-compassion and to have a low threshold to ask for help, because this is a very challenging time. And that is the end of my part.
All right, thank you all so much. That was very informative and very helpful. So at this time, we will do some questions. The first one that came in is, does Hackensack Meridian offer pelvic floor therapy?
Yes, they do. I know I can't speak to the upper campus, but the North Campus, but I'm sure they also have a center. But for certain, JFK has an HMH centered, an HMH pelvic health center, as well as Jersey Shore and Neptune, and they accept all insurances.
Thank you. The next one, next question is, could you start this more than 6 months postpartum?
Yes, so I can clarify that as well. So I would say you could start pelvic floor physical therapy as soon as, your lacerations have fully healed. That's typically your OBGYN will give you the go ahead at your appointment at around 4 to 6 weeks. But of course, everything's different depending on the tear. What I meant by the 6 months is while you can start physical therapy in the postpartum period, again at like 6 weeks or so, if at the 6 month period, you've been doing your pelvic floor exercises, you've been mindful of, what you're eating and drinking, etc. If at 6 months you're still kind of leaking, peeing yourself, etc., having issues with fecal incontinence, I think seeing a urogynecologist at that 6 month mark or considering it is appropriate, but definitely you can start PT before 6 months.
All right, thank you. The next question is there a diet that I can follow to help regulate hormones?
Well, in general, I always say that the liver clears excess hormones from the bloodstream. So a balanced diet with natural and unprocessed foods is best to promote hormone regulation. You want to continue prenatal vitamins, and which are high in folic acid and antioxidants, which help the liver function properly. And you want to supplement calcium if your diet is not rich in dairy or calcium sources. And just remember to drink plenty of fluid because that also helps the liver process.
Thank you. The next question is, what can a mom do about if she pees while she sneezes?
Yes, so working on timing your fluids, Kegel exercises, so those pelvic floor strengthening exercises, that's sort of, again, your first line treatment. After that, in consult with the urogyne, there are procedures that can be done in the office, such as fitting you for a vaginal insert that can help sort of give you more support to the urethra, doing a bulking agent or a gel filler to the urethra without anesthesia. Again, go home the same day, because I know everyone's busy as a mom. And then, of course, down the line, things like surgeries, like with a sling implant, but definitely starting with physical therapy, pelvic floor exercises, things like vaginal inserts is where I would start with for conservative measures.
Okay, thank you. The next question is, what is a gauge or indicator to seek treatment for postpartum depression or anxiety?
That's a great question. Of course, there are scales that we can do, but I would say if you are wondering if you might be having symptoms of postpartum anxiety, I would have a low threshold to ask your OBGYN and seek out help because, best case scenario, it's something that, doesn't necessarily need medication treatment. But it's never a bad thing to get an opinion about it. And it's certainly a good thing to be proactive so we can kind of prevent more severe, like any worsening.
Thank you. The next question is, do you recommend visiting urogynecologist yearly, similar to an annual physical?
I would say I would start with an intake visit. That's usually a longer visit. It's typically around like 45 minutes to an hour. And then pending on the treatment plan we determine, we usually do a short interval follow-up at 3 to 6 months, and then we can space out longer as needed. Typically not yearly like an annual physical though.
Okay, thank you. How might the thyroid come into play, like hypothyroidism?
In the postpartum period?
Yes.
Postpartum is an interesting time for thyroid function. Generally, hypothyroidism is common in pregnancy. It's also, if you have a history of hypothyroidism, you will probably need medication adjustments during pregnancy. In the postpartum period, what we can see is a postpartum initial increase in thyroid function, which is a postpartum thyroiditis, probably related to hormones, thyroid hormones, that is, or antithyroid hormones. What happens after that is it kind of burns out, and then in the postpartum period, women may experience then a hypothyroid state. So any signs or symptoms of changes in thyroid function, things like dry skin, heart rate changes, just your energy level changing, all these things need to be brought up to your provider in the postpartum period. And it's very simple to check thyroid hormones and thyroid antibodies to see if you are possibly experiencing a postpartum thyroid issue.
Great, thank you. The next question is, what are some specific ways a mom can ask for support in the postpartum period from her partner, family, friends, etc.?
Yeah, that is a great question. And it's something that so many people have a difficult time with. One, I will say if people offer support and it's support you would like, again, not all support that's offered, a lot of people like to offer to hold the baby, and that may not be the thing you want. You may want help with your laundry or your dishes. But if there's a match with the support that is offered, say yes. It can sometimes be difficult to accept help that's offered, let alone ask for it. The other thing I would say is just ask for what you would like specifically. I know it can be really, really hard to do. But and you may get some no's, but the more you practice asking for something, the more the no's will not faze you. And the more comfortable you'll feel with it. But it's certainly not a time to be shy with your support system.
Okay. The next question is, what tips do you have for postpartum moms going into perimenopause?
Well, it's kind of an interesting time to be going into perimenopause because you are already almost experiencing menopausal symptoms in the early postpartum period because your hormone levels, especially your estrogen and progesterone levels, are so low. As far as that goes, it's kind of hard to discern that transition. So some of the things that you might expect to experience that may not happen and kind of give you an idea that it might be a more permanent hormonal change is if you cease breastfeeding and perhaps your menstrual cycle doesn't return normally, or your menstrual cycle is now irregular. You also may notice that some of those changes postpartum, the vaginal dryness, the sexual kind of discomfort is not improving in the normal time frame, which is usually either at the end, after the end of breastfeeding, or generally around the 6-month mark. You'll start to see improvements again in those things. As far as just kind of a delay in returning to normal hormone function postpartum, it doesn't always occur just right after you stop breastfeeding. It doesn't always occur, 6 months postpartum, but it is something that can be monitored by your provider. And also you can have certain tests done to assess whether or not you're entering perimenopause.
Okay. We have time for about 1 or 2 more questions. So the next one is, what is the best way to naturally restore mental clarity? I have a lot of brain fog, makes me very emotional, depressed, and anxious, which then turns into insomnia.
Yeah, that's a great question. And it kind of goes back to this idea of, so there definitely are brain changes in pregnancy. One specific area of the brain that does change, perhaps as kind of an evolutionary way to conserve things that aren't as important, is the area of your brain that remembers names, because names are less important than, in the postpartum period, you're focusing on keeping a very vulnerable human being alive. The other thing I will say though is, brain fog can be so multifactorial, and I don't want you to underestimate all of the things that can be contributing to this, which includes just even if it is causing insomnia, there probably is insomnia already postpartum, which will certainly not improve mental clarity. Just the overwhelming number of things a mom has to kind of do in the postpartum period, particularly if there's not necessarily even inadvertently inequitable division of like household labor. It's possible you're taking on a lot more things than you realize you are, which will of course decrease your like cognitive reserve and make it a little more difficult to think. Of course, if there's psychiatric illness like postpartum anxiety or depression, that too could be making it, worsening brain fog. So I really, really would want to make sure that we are, optimizing all the things we can. And, it will eventually improve as long as we address kind of all the different factors.
All right, thank you. And the last question is, how come pelvic floor therapy is not talked about postpartum, or the doctor just suggests to do Kegels?
That's a great question. I think, it's important to change that stigma. I think, in Europe, in France, for example, you actually get covered like 10 sessions of physical therapy and you leave the hospital with that referral. So the United States, I think, to your point, is behind in spreading awareness about pelvic floor health. And unfortunately, a lot of doctors, it's difficult to spend the time to review all the pelvic floor disorders. I mean, Kegels, again, is a certain place to start. And I think that's kind of how Urogyne became a field. But there's a lot of also, I do want to say, a lot of pelvic floor physical therapists actually have social media channels. And our Society of Doctors actually studied the reliability of what's put out there by these social media channels versus our society guidelines. And they actually did find a correlation or through a reliability index. So I tell patients frequently, if you're online and you see someone with like a DPT or a doctor of physical therapy with a specialized in pelvic health, there's only 2,000 of them in the United States out of like 300,000 physical therapists. So there's not many of them. And the ones that do go into it are very passionate about what they do. So definitely using social to see kind of what some of these physical therapists have put out there is very helpful. But I agree. I think the US is behind when it comes to pelvic health.
All right. Thank you so much, Dr. Ross, Dr. Kaplan, and Dr. Sansone. This was very informative and very helpful. And I thank all of you for taking the time tonight to join us. Please watch your email for a survey of the program. Please take the time to fill it out. We want to hear from you. You can also let us know if there's other topics that you're interested in. The link to the recording of the webinar will be included if you'd like to listen again or share it with others. For our moms that may be down the shore or want to travel down to the shore, we'll be hosting another event in collaboration with Monmouth County Moms at the beach in Belmar on the boardwalk next Friday, June 7th at 10:30 a.m., where it'll be a walk and learn mom meetup with one of our pediatricians. We'll also be hosting a All About Fibroids webinar on July 24th. So you can visit our website at hmh4u.org/events to register and find out more information about these upcoming programs and others. I hope you all enjoy the rest of your evening, and thank you again for joining us.
Thank you. Have a good night.